We're, we're now ready to go, Kevin.
Okay, well, good morning, everyone. Thank you for those of you that are able to join us this morning for the Wednesday, April 6, 2022 meeting of the Health and Wellness Advisory Committee. I want to thank Paul and also Mike Seekings for all their work over the weekend and for the past few months. Because of their work and others, the Cooper River Bridge Run was a great success this past weekend. It brought in, as you know, every time, thousands of people for fun and healthy event, and showed our area in a very positive light, and also boosted our local economy a little bit. But I also want to congratulate Paul, who was the recipient of the Joseph P. Riley Community Service Award, which is an award given every year before the Cooper River Bridge Run. And some of you know that Paul served on the board of directors for the Cooper River Bridge Run for 27 years, and he served as the board chair this year. So a lot of deserving people have won that in the past, but none more deserving than Paul. And we know all the great work you do with everything you lead. So congratulations, Paul, and thank you for all your work. So
Thank you. I appreciate it.
Want to let you know too, I also spoke with Lori Yarborough last night and Mayor Tecklenburg this morning. They both asked that I send their apologies, but they have a conflict and won't be able to attend this morning. But they also asked that I thank everybody for their work and everybody that's been here. So we are going to skip the approval of the minutes this morning, and we will approve those at the next meeting. But we're going to start off with a discussion on mental health and suicide prevention with the South Carolina Department of Mental Health Suicide Prevention Team. And I'm going to let Jennifer Roberts introduce our speaker, if she would.
Yes, thank you. And thanks for letting us present this today. So Jennifer Butler is with us from the state office, South Carolina Department of Mental Health. She was over suicide prevention for many years and has done many other things with the department, but now she is the director of emergency services. So that includes suicide prevention team, mobile crisis teams across the state, crisis stabilization units, embedded clinicians in law enforcement, and probably a few other things, right, Jennifer? I don't know, but she's here today to present some interesting data for you. So welcome, Jennifer.
Thank you. Good morning, everyone. I hope you're all doing well on this post-stormy day, and hopefully everybody's safe who's watching this. Now, we're going to talk this morning about some suicide prevention information regarding the data, some particular Charleston related data, as well as just understanding the landscape and how we as community members and community leaders can be a part of preventing suicide. So I'm going to attempt to share my screen. I will give you a heads up. Technology is not always my friend. We're going to go for it and see how it looks. All right. Are you able to see just the finding meaning? Okay. Yes. That's a surprise that actually worked. We can still see it. Perfect. All right. So I've titled this Finding Meaning because when we talk about data, oftentimes it can feel cold because you're talking about numbers, but these numbers actually represent lives lost, lives who are struggling, survivors of suicide loss who are in pain and grieving. And so I want to make sure that as we talk about data, that we use data to help us understand what are the next steps. If we're seeing an increase in a certain area of the population or a certain area in the state, what are the next steps to make sure that we don't lose anyone else to suicide? We're also going to talk about finding meaning and how we each can be a part of preventing suicide. Sometimes that feels like a daunting task. Or you may even think, well, is my community sector really involved in preventing suicide? For example, with realtors. And so we actually tabled at a Realtors Association meeting in Aiken, and some folks were like, this is odd to go to a realtors conference. But actually that community sector, when someone dies in a home by suicide, that has to be reported out, or the stress levels of selling your home, or even being the realtor yourself. So making sure that we kind of find meaning in why we need to break the silence about suicide and how we can increase community flourishing. So within this talk, we're going to weave in the overlapping themes of resilience, empowerment, and ultimately hope. Hope has to be embedded in all of our conversations so that we are able to make sure that those who are struggling, that are in our community, know that there are resources available to help them through this crisis. So let's talk a little bit first about what suicide is, what the thoughts and behaviors are. Suicidal people are typically suffering from a great deal of emotional pain. We find sometimes, particularly, for example, with the pandemic, where folks were like, can you tell us how the pandemic is impacting suicide? Well, it did have a great impact, but suicide really can't be boiled down to one issue. It's usually a emotional storm of maybe a prior mental illness, maybe something like social determinants of health, of not having access to resources for a thriving way of life. It could be also then opportunity and access to means in the middle of a crisis moment. And so as we think about this, thoughts of suicide are common, but actually dying by suicide is not as common, and I'm going to show you a little bit later just how common suicidal thoughts are. Most people who experience that suicidal ideation do not die by suicide. And this is a hopeful stat here. 93% of people who attempt suicide do not go on to die by suicide later in life. And you may say, okay, well, why? Well, because usually after they've had an attempt, ideally they've gotten resources, they've gotten the care that they need, they've gotten the family support, the community support around them to help through that crisis, and they're able to work through what's going on in that moment. The range of suicidal ideation varies greatly from just contemplating it all the way to actually acting on that suicide attempt. Most often, it is not about dying. It is about ending pain, ending physical pain, mental pain, spiritual pain that feels unbearable in that moment. So here's where we're going to move into some of the data. So in 2020, 868 people died in South Carolina by suicide. So that's up from 2019. It's up by 16 deaths. And the national suicide rate number went down in 2020, but South Carolina's went up a little bit. We're ranked 24th in the nation for suicide deaths. Ideally, we would at this point be able to tell you in South Carolina how many were kids, how many were adults, how many were this particular race and ethnicity, where were they in the counties. But unfortunately, because of the pandemic, that has really slowed data releases. And so we still don't have South Carolina's breakdown in that way. But we can show you a little bit about some other what we call real-time indicators of distress. So because death data can have such a long pause before we actually get it, we look at things like the number of calls to the Lifeline that came in from South Carolina. Are you all seeing the slides?
They're not advancing.
Okay.
Still on the first slide.
All right, hold on. Let me see if I can.
There
What do
you
you
go.
see? Can you see just the slide now?
We can see your notes also, though,
All right.
which is not the end of the world. It's information you're saying.
All right, there we go. I'll just leave it up and you all can say, all right, this is what she's saying. So if you look at this with these real-time indicators, what we look at is the number of people who called 911 with a suicidal thought or an attempt in progress. We also look at the number of individuals who actually walked into an emergency room in South Carolina with either a suicide attempt, suicidal thoughts, and then in the last 6 months, we began tracking mental health trauma. So if you look at these stats, you can see that our suicide death rates have actually steadily increased. And in 2020, there were 6,801 individuals who received care in the ER for suicide attempts. So that was one person every 77 minutes in 2020 walked into an emergency room in South Carolina after an attempt. Now that's actually down, even though that's a very alarming number. And so when we first heard the numbers, because we had the attempt numbers, the number of folks who walked in with ideations before we had the death numbers. And so we were sort of holding our breath to see if that was an indicator of hope. But if you remember in 2020, we were in the middle of a pandemic. And so many people may not have been able to go to the emergency room to actually seek care. And of course, these numbers only track those who walked into an emergency room. Not everyone who attempts suicide actually seeks medical treatment. If you look at the number of folks who were seen with a suicidal ideation, that's an alarming number. We're talking just shy of 24,000 people. That's one person every 22 minutes that walked into an emergency room in South Carolina with a suicidal ideation. And when you look at the number of those who went in indicating mental health trauma, it's also an alarming number, about 22,584. So that's one person every 23 minutes. So you can see why resources are so important and making sure that we're able to get these out to folks because we're seeing distress. So as we look at how many of those EMS calls were made, there were 16,176 EMS calls in 2020. And you can see what a high jump we had in 2021, a 40% increase. So that's quite alarming to think that we had such a big jump from 2020 to 2021. And when you look at the mobile crisis program, they responded to just shy of 22,000 calls. 7,450 of those were crisis calls, resulting in about 1,800 mobile responses across our state. So the other thing that sort of happens is sometimes when I present this data, I remember there was a community member once that said, Jennifer, you're punishing us because we're calling and you want us to call. We do want them to call. So I think these numbers also represent both the level of distress that individuals are in, as well as how often they are able to seek resources. We want them calling in. We want to see the numbers. I would rather see high numbers here than high death numbers. So when we think about the Lifeline, the National Suicide Prevention Lifeline is operated in South Carolina by the Mental Health America of Greenville County. They're our only call center at this time in South Carolina. We're hopeful that we're going to get funding to start a second one that actually will be in Charleston with Jennifer Roberts and the Charleston Dorchester Mental Health Center. So and if you think about in 2021, there were 26,476 calls to the Lifeline from South Carolina. Mental Health America was not able to answer all of those. So we had just shy of 8,000 that went out of state or to the Veterans Crisis Line or to the Spanish language line. 988 is coming July 16th, 2022. It was passed into law by Congress in 2020. They gave each state 2 years to ready themselves for this launch. So that 10-digit number is going to go down to a 3-digit number. So it's easier to remember, which will increase access, which is a good thing. But we also have to be ready for it, which is why we need as much support as we can in asking our legislature to fund the entire continuum of care for 988. So when we think about that entire continuum of care, what we're talking about is who answers the call. So that means trying to get 2 call centers in South Carolina so that 100% of calls are answered by South Carolinians who know our resources, who know where things are in our state. Who responds to the call? That's our mobile crisis program. We are blessed in South Carolina to have a mobile crisis program across the entire state. But we need to make this more robust. We need to make sure that our rural areas have more than one team so we can reduce response time. We need to make sure in our high volume areas like Charleston, they have more access to more than one team at a time to make sure that we're able to respond. And expanding telehealth, as well as where do they go? Right now, South Carolina has 1 crisis stabilization unit, and that is in Charleston, South Carolina. But if I'm in Anderson and I need to go somewhere, I'm not going to get a bed in Charleston to be able to go and seek that care. So we're also asking the state legislature to fund 7 more crisis stabilization units across the state. So you can see that we're really trying to enhance and strengthen the crisis response continuum of care in South Carolina. Part of 988, or the National Suicide Prevention Lifeline, is that they also offer chats and text messages. So you can see there were just shy of 5,000 out of South Carolina that came in chats and texts. South Carolina is also partnered with the crisis text line, and that one actually had 13,000 conversations that came through. So if you remember a little bit back, I said I was going to talk about how many people are actually struggling with suicidal thoughts. The 10.6 million adults and 3 million youth in the United States struggle with suicidal thoughts on a daily basis. These are not necessarily the individuals who are acting on it, but living in quiet desperation. So part of preventing suicide is making sure that we are increasing resilience in the community, increasing protective factors in the community for those who are struggling every single day with wondering if life is worth living. So let's dive in just a little bit to Charleston. So this is for Charleston County. So if you look at this graph, you can see that in terms of sex, male or female, and all of our information comes from DHEC labeling. So you can see that there's been a steady increase for both male and female in Charleston from 2016 to 2020. So it continues to go up. When you look at this graph, you can see this is broken down by the ages. This is the first time we've actually looked at children under the age of 10. And this came from really a call to action from the Palmetto Poison Control Center, as well as child advocates that said, we've got to really pay attention to these elementary school age children. So if you look at that, you can see that the 15 to 19 in Charleston had an increase. The 20 to 24-year-olds had a tremendous increase. Again, 45 to 54. And then if you look at the 85 and over and 75 to 84, they also had an increase. What I like about this slide is that it kind of will point in direction in terms of a community group, such as yourselves, a community leaders, to say, okay, well, what are we doing with our middle school and high schoolers? What can we do with our college age kids in Charleston County? What do we need to do with our older adults to make sure that they have access to resources, they have access to care? So as you look at this one, this is attempts by sex. And so you can see the attempts actually went down, whereas the deaths were up. And so unfortunately, I'm not sure if that really means that we're seeing more individuals dying by suicide than are attempting. But again, the attempts are going to come from only those who went into the emergency room, whereas the death, we're going to get that from all death records. So as you look at this one, you can see that for Charleston, that 85 and older had a pretty significant jump in 2020. And so looking at what is going on with them, I can tell you that statewide, that 10 to 14-year-old population has been the only age group that has consistently gone up for the last 5 years. And so even though in your county they went down, statewide, that is an area of concern with 10 to 14-year-olds. And also the 25 to 44-year-olds have been struggling statewide the most. All right, so no more numbers. Let's talk about what do we need to be mindful of. When we think about risk factors, think about things like, as it says on the screen, traveling along life's path, and protective factors are like your seatbelt. They're like checking your tires to make sure there's enough air, having good windshield wipers in a storm, those things that we do that are around us to protect us while we're traveling down the life's path. Whereas risk factors might be those bumps in the road, the potholes, or a tornado, storm. And that could look like substance abuse, poverty, violence in the community, things that cause us to step off our path. So when we look at risk factors, this is, and I'm going to talk in just the next slide about who's vulnerable. So in looking at the American Indians and Alaskan Natives, these are some of their risk factors related to suicide, but they're actually common among anyone. So historical trauma, cultural distress, family disruption or abuse, mental illness and its stigma, substance use, anything that is going to lay heavy on not only the individual, but also their community. So who is vulnerable? As you look at this list, there may be other individuals that you say, well, what about this population? Well, the truth is, yes, these are the populations that have the higher numbers, but remember, we're all at risk. It really should be, this slide says, everyone, because just because you're human, we're all vulnerable to having that darkness overwhelm our capacity to cope on any given day. No matter how strong we are, how many resources we have in place, we're all vulnerable. So what do we look for? This is a phrase to kind of remember the warning signs of suicide. So what I want you to remember is really two words: change and pain. So if someone is having physical pain, mental pain, spiritual pain, that's an indicator of a risk factor for suicide. And any change, so are they having a change in their mood? Perhaps they have become more depressed, but perhaps they were depressed for a while and now their spirit is lifting. That is not a sign of, necessarily of, things are moving in the right direction. That actually could be a sign of they've come to terms with taking their life. Check in if there's a change with emotion, if there's a change in behavior, if there's a change in the way they appear, their appearance, the way they're interacting in relationships. Check in. You know, we had back in 2001, after 9/11, we had the see something, say something. And that was all about if you see something that looks like it's out of place, like a backpack, right? Laying there that nobody knows where that came from. And we were supposed to say something, right? So that the backpack didn't explode and didn't destroy everything around it. You have to do that with suicide too. If you see something, say something, because otherwise that may result in a death that then impacts and devastates all those around them, the community around them. So thinking about all of these things, kind of just make sure we check in no matter what. So what are protective factors? These are some that are listed here on the screen. What I want you to remember most about protective factors is one protective factor can sort of negate the impact of 4 risk factors. Just one. You may have heard that if you've ever experienced trauma training, and they've said, you know, if an individual has 1% in their life, they can survive a trauma better. But think about this in terms of really all of you are protective factors. You have the ability to go into your community, into your daily lives, and really help individuals who have multiple risk factors. Even though you're taking this training or you're hearing me talk because you're in a meeting, that doesn't mean that this is the only time you should be having this conversation. Have these conversations with your family, with your friends, your church members, your neighbors, and think about how can we help Charleston County increase these protective factors. So this is a quote from the Canadian's First Nation elder, and it says, "Silence is dangerous when we pretend the problem is not there. Communication is a healer to break the silence." So I was meeting with a church here in Richland County, and they said something very similar. They said, "Jennifer, we act like this isn't happening in our community and we're dying." And so it's important that we remember that we're ethically responsible for the lethal use of language. And so what I mean by that is a couple of things. Number one, if we don't use language at all because we don't check on each other, if we just see something or we just keep passing by, but also if we use language that is stigmatizing, saying things like, suicide's a sin, or why on earth would you want to do that? You have everything. Or even just kind of using language in our everyday interactions that doesn't allow for connection to another human being. that destroys the hope and the resilience of our community and the individual we're working with or interacting with. We're ethically responsible for that because that stays with an individual, and it is imperative that we embed hope in all of our communications. So what do we, there's a training called Talk Saves Lives, and it sounds like a really simple concept, right? I just need to talk about it. Well, it actually can be that simple. Have conversations, not necessarily when someone is in crisis, but go ahead and start having conversations about suicide is something that is of concern in Charleston County. And what are we going to do about it? We're going to be a part of the solution, a part of the flourishing of our community. So having those conversations with people when they are in the midst of an ideation or a suicidal crisis, connecting them to resources. And when someone dies by suicide, making sure that we wrap love around those lost survivors. And remembering that sometimes we are the lost survivor, whether that's we're the clinician or we're the teacher or we're the employer, we are also considered a lost survivor. And I don't know that we always identify ourselves. We just keep moving, and that trauma keeps staying with us. As a community, the more that you can talk about suicide and make this a safe place to talk about it, the safer your community will be. So why don't we talk about it? A lot of reasons. If you think about minority cultures in particular, there may be historical trauma or cultural issues regarding guilt and shame, where it's not okay to say you're not okay. We don't have those problems. It can also be a collective grief with a great deal of that unspoken conversation. And maybe we don't do it because we think we're being polite or respectful by saying, well, I'm sure they don't want to talk about this because this might be too much for them. Well, it may be, but also we've also heard loss survivors say, no one will say my child's name. No one will say my husband's name because they're afraid to talk to me because the person died by suicide. It's a death, it's a grief that we have to wrap love and care around, just as any other death. So how do we do this? Many of the barriers to conversation are really kind of boiled down to how and when we have these conversations. And again, having them when we're not in crisis, having them when we are in crisis. And if we're the professional in crisis, being willing to own that and have that open and productive conversation. We did a faith training recently called Soul Shop, and it was actually hosted in Charleston County. And it was the first time South Carolina was chosen to do this pilot. And so it was Soul Shop for the Black churches. And this came up a lot with them about why they don't have these conversations and why this was a barrier, particularly in their faith community. And so we had a really open and productive conversation about what it has to be. We have to change how we're looking at this, and we have to change how we interact. So successful prevention is going to rely on all of us, the entire community, and making sure that we are working on bringing in community members who have that lived experience, who understand that walk through those quiet, desperate moments, as well as that walk through loss and pain. So how are we going to help our community flourish? Just like suicide can't be boiled down to one thing, our approach can't be one way. Suicide needs to be prevention needs to be a layered approach, lots of training, lots of reminding communities of resources, using our voice as advocates to say, for example, maybe going to Charleston County Council and saying, we need more money to fund resources in our community. Or we need to really think outside the box of how we're going to do this in our county in terms of suicide prevention. Making sure that everyone knows how to do this. I was there at the Low Country Conference last year, and we were walking down this, I'm not sure what street I was on, but a very cute street with lots of shops. And I walked into Wolfgang's Barkery, and I just took a chance to say, can I talk to you about suicide prevention? As it turned out, he was a veteran. He knew he had lost friends to suicide, and he said, I want to be a part of this. I'll put the Lifeline flyer up in my window. I'll give out things in the bags when people check out. And he's continued to do that. And that's sort of a really great way of saying, we all have a part. And something simple is just starting and asking businesses to say, will you post something in your window that talks about resources, that tells people where they can go? Imagine if you were walking the streets of Charleston feeling alone and you started seeing everywhere, your life matters and here's a resource. Think of what that would feel like. So prevention success can't rely on just one family, one neighborhood, one institution, one level of government. It has to take all of us. The stronger we are, the more we band together, the more resilient we will be. And the majority of those dying by suicide in South Carolina, and this is also a national trend, are not in a formal system of care at the time of their death. They're not, for example, within the Department of Mental Health at the time of their death, or if a veteran within the Department of Veteran Affairs at the time of their death. So who are they interacting with? They're interacting with you, with their friends, with their coworkers, with their church members, with their neighbors, with their business owners. And that's why this is going to require a community approach to preventing suicide. Just like we all learn CPR. I watch a lot of Grey's Anatomy, but I can't perform a surgery. So I've taken CPR for many years. CPR doesn't mean that I can go and do heart surgery, right? If I find someone that is in distress, it means I can give care until someone else can come. And that's what we have to start to do with suicide prevention. So lastly, the greatness of a community is most accurately measured by the compassionate action of its members. We need actionable change, not just conversation. And we do need the conversations, but we can't stop there. We need actionable change. Really saying, okay, we heard this information, and I think there are going to be slides sent out that give you even a deeper dive into Charleston's numbers after this meeting. But really thinking about, now what do we do? What is the next step? So that we can make sure that we don't lose any more lives, any more South Carolina voices to suicide. And that is everything, unless there's a question.
Well, thank you very much. Great information. And I do see that Dr. Annie Andrews put something in the chat on an article. So if you'll reference that as well. And thank you for that. And very good presentation, a lot of great information. Any questions?
I don't have a question, but just a quick comment. Thank you so much for that presentation. That was really fantastic, great information. And I just want to mention that when we're talking about youth suicide, we have to remember to talk about secure firearm storage in the home, and that can greatly reduce the risk. And that's an action we can all take today without any additional community resources or legislative change. So we just need to talk to the adults in our lives about securely storing their firearms in the home as a means to reduce youth suicide.
You are absolutely correct. And in South Carolina, the #1 method of suicide deaths is firearms, of course, nationally as well. And the #1 method for attempts is poisonings. And so that was part of the reason the Palmetto Poison Control stepped forward last year, is because they were actually seeing very young elementary school age children who were intentionally ingesting poisons to die. And so I think that you're exactly right. The lethal means conversation has to occur. And research shows that if a doctor or a physician or a medical professional in that person's life talks about lethal means safety, the individual, the parent, is 3 times more likely to actually follow through and safely store. So it's very important that we have those conversations.
Thank you. Paul?
Hey, I like the idea that your life matters. Is there a resource, a poster or something with that kind of information on that we could distribute?
I think we can create one. One of the things I didn't talk about was that we started last year, the South Carolina Communities of Care. And it is this community approach. It's the very first time that zero suicide, which is a healthcare framework, is being allowed to be used in the community setting. we chose the 10 counties that had the highest risk factors, whether that was death or that was real-time indicators of distress and some other factors. Charleston is one of those counties. So we've been searching for just individuals or organizations that will post something and say, I'm a South Carolina Communities of Care partner. But I think that we could definitely, with Jennifer Roberts' help, kind of create something that said your life matters, and then what resources you would want on that. I think that's a fabulous idea.
And I had a question. I know when you had that list of at-risk on there, one of the first ones was American Indians and Alaskan Natives. Is that an issue in the state of South Carolina, or is that just a national thing? Is it just on there in the tribal areas, or what's the situation there?
It is a national thing. Their rates are going up. I was talking to the Catawba Nation folks yesterday, and their number in particular is low, but they have other indicators of risk factors. So other indicators of substance abuse, maybe violence in the community, poverty, and things like that, that are impacting their risk, their vulnerability. And so those are universal. And so even though Catawba Nation is our only federally recognized tribe, we have several state recognized tribes that we're now partnering with Catawba Nation to say, can we then help them go into the other state recognized tribes and talk about these issues? But that definitely is a national concern. And one of the things I'll say in terms of minorities is that, and I apologize, this is how DHEC reports this information out when they look at race and ethnicities, they only say white, black, and other. Well, other could be lots of things. And that's not very helpful to lump it into one little segment. But what we've seen in South Carolina is that the folks who are falling in the other category are actually going up. Whereas we may see the white and the black numbers going down or kind of staying the same, the other race continues to go up. And so that's also something important to think about. We're about to launch a billboard campaign in both English and Spanish that links them to a mental health screener so they can connect to care. And so even I think as you think about signage, we could look at making sure we do some of that in Spanish so that you're able to post that anywhere for anyone to see.
Great, thank you. Any other questions?
Kevin, this is Joey Current with Trident United Way. I just wanted to remind the folks on this call to, as we stay consistent with presentations that we've heard before, suicide was, as a reminder, one of the top causes of premature death in South Carolina in 2020, right? Which all contributes to the disparities in life expectancy that we see across our county. So just to tie everything together, this is a great presentation. We really appreciate you coming to speak with us today on it.
Thank you, Joey. Anyone else? Well, Jennifer Butler and Jennifer Roberts, thank you so much. Great information. And we very much appreciate your time and getting this out to us. So thank you so much. All right.
Thank you for having me.
And if there's nothing else on that item, we will move to the community health update and ask Dr. Katie Richardson if she'll give us a report, please.
Thanks, everyone. I too found that information really helpful. And if you share the presentation with Paul, I'd love to share it with some folks here at DHEC. Thankfully, the news around COVID is largely good today, which is great to be able to say after 2 years. We had statewide 951 cases this past week and 2 deaths. Those numbers do continue to go down here in South Carolina, although we have seen some up trends in the Northeast and a few other states. DHEC has transitioned to weekly presentation of data that comes out every Tuesday, and it provides data from Sunday to the Saturday before that Tuesday. And Other than that, I did want to just mention the BA2 variant. That is a variant of the Omicron, and that we believe is some of the reason for the increases happening in some European and Asian countries, and perhaps the Northeast as well. CDC recently said that over half of cases reported are now the BA2 variant nationwide. Our public health lab, the last time our whole genome sequencing samples were run, about 10% were the BA2 variant here. And the last time I checked with MUSC, who does whole genome sequencing on all of their positive PCR results, they had seen no BA2 variant, although they were because they're just less specimens coming in, they do want to get sort of sufficient numbers to do a run. So it had been a few weeks since they did that. We do have in the state antivirals, the Paxlovid being sort of the most popular and the most efficacious. Those are available at pharmacies for those that qualify, which are people most at risk for severe consequences from the COVID infection. With CDC's new sort of community level rating system, all of our counties in Low Country region, including Charleston, are in the green zone. And that looks at sort of three metrics. Two of them are hospital-based, COVID-19 hospital admissions, a rate over the past 7 days, and the percent of staffed inpatient beds occupied by COVID-19 patients, as well as a more general rate of new COVID-19 cases in the past 7 days. And all of those need to be in the green range for there to be an overall green or low community level. And so those also come out once a week, and we will continue to follow those such that if we see increases, additional recommendations may come out to prevent continued increases and a possible transmission, possible surge. So DHEC is moving from an instant command system to a COVID office. I think that's happening at many healthcare systems as well. We've also given recommendations to the schools that given the 2 weeks of less than 10% of the community, meaning students and staff, being positive, they also can choose to suspend contact tracing, testing, and quarantines. If they so choose. There is still testing available for students and staff in the Charleston County School District, and that funding does go through sort of midsummer for that funding. The one other thing that's happened on the COVID front is FDA and CDC have approved a second booster dose or a fourth dose of the Moderna or Pfizer COVID vaccine. That's for those who are age 50 or over, as well as those who are immune compromised. That's based on mostly on data out of Israel, who back in early January began offering a second booster to healthcare workers, as well as those over 60. Different countries have used different criteria. Germany is used over 70, nursing home residents, immunocompromised, and healthcare workers if it's been 6 months. But right now, CDC and FDA are using 50 and over, and those who are immune compromised. It is not, it is permissive guidance. So it is not a recommendation per se, but it is a, for those who would like to get it, it is allowed at this point in time. And I certainly hope that more data will come out soon. I'm glad that it's available. I know that some people are taking advantage of it and others are waiting to see more data to be further out from their last booster. But especially for those who are older and those immune compromised. I'm glad that it is an option. I think that's all I have to say about COVID. I did just want to mention our SHAPE initiative, our sexual health awareness, STI prevention and education initiative. After our last meeting, Paul and I spoke, and he had a great idea to think about perhaps doing some what we would call fast track cities community chats. So fast track cities is the proclamation Mayor Tecklenburg signed on to several years ago to work to end the HIV epidemic here in the city of Charleston. These community chats would really be a way to begin continue and sort of re-energize the conversation around HIV, around the SHAPE initiative and what we're hope to do, and to expand it not just in the city of Charleston, but also across the Tri-County region. So we got a suggestion, Paul, to present it at the next Mayor's Commission on Homelessness and Affordable Housing. That happens at the end of May. My understanding is that brings together passionate volunteers from across the Tri-County area. We certainly know that those are risk factors for HIV. And so we're hopeful that maybe that group will partner with us to assist in helping us to identify locations and those who may be able to join us for those. So just wanted to bring that up to this group. Certainly, if anyone is interested in working on that, let me know. And what else? I wanted to say just two other things. DHEC is having a free testing day for STIs on April the 12th. That includes chlamydia, gonorrhea, syphilis, hepatitis C, and HIV. Paul sent out the flyer for that. Please help get the word out. Unfortunately, we have seen increases in most of our sexually transmitted infections over the COVID pandemic time. And one last plug for the inaugural LGBTQ Health Summit through MUSC. That's happening tomorrow and Friday. It is free registration. It's virtual to attend, and there are lots of great speakers around healthcare for the LGBTQ population. And so I think you can find it with a quick Google search, but if you have any trouble and you're interested, you can attend part or all of it. I'm happy to send the registration. Thank you, and I'm happy to take any questions.
Thank you, Dr. Richardson. Any questions? And Tracy, I know a lot of times you jump in when Dr. Richardson's here, not to put you on the spot, but I just wanted to make sure we didn't leave you out. So.
Good morning, everybody. Nothing really to report from the city this morning. Definitely just, as always, thank you, Dr. Richardson, for all the support that you've given to the city during the pandemic. So we really appreciate it. Thank you.
Thank you, Tracy. Tracy's been extremely busy lately, and we appreciate her joining in this morning. She's been doing a lot for the city, a lot of meetings and a lot of time she's put forth. So thank you, Tracy. And I do see that Dr. Andrews had another thing in the chat. So if you'll take a look at that when you get a chance. Any other questions for Dr. Richardson, Paul?
I always have a question for Katie, but Katie, the second booster shot, is that what clinics are doing that? Is like MUSC, Roper, everybody got it, or is it just isolated?
I'll let Meredith speak for Roper, and Annie, if she knows about MUSC. I can speak for the DHEC. We continue to have vaccine available at all of our health departments at least one day a week. And that can be both walk-in or by appointment. And then I know most of the pharmacy chains continue to have the vaccine available. And again, that can be walk-in or by appointment. Meredith or Annie, do y'all know specifically for Roper and MUSC?
I can't confirm, but I assume it continues to be available, just like you said, at all the MUSC pharmacies and clinics on a walk-in or appointment basis.
Correct. And as for our Roper St. Francis, it's all of our express cares. So all of those have it. It's more of a walk-in type of thing as well.
Thank you. And there is still the vaccine locator, if you want to see all of the options in your zip code.
Katie, one other question. I heard about immunizations reminders out there again, and I thought you might want to give another plug on that as well, too.
Yeah, so as many of you remember, Dr. Kanaka joined us recently to talk about delays in childhood immunizations around the pandemic, during the pandemic. We did send out a HON, or a health alert, to our network since that time, because we've had 2 different outbreaks of varicella or chickenpox in our communities. One of them was in the Charleston area. So it is a good reminder that there are lots of other vaccines that are highly effective and do a great job in preventing illness, and that kids who may have delayed going to pediatricians for well child checks during the pandemic, this is a great time to make those appointments and get caught up.
All right, very good. Anything else for Dr. Richardson? We still have about 10 minutes left, and we've got one other item on the agenda here, but thank you very much, Dr. Richardson. Thank you very much for your report. Appreciate that. And we do have one more item on the agenda. We'll kind of go around. Dr. Andrews, anything from MUSC that you'd like to report?
No, aside from what I already put in the chat, which is this Friday, the annual PITS lectureship, which is actually run by the ethics department at MUSC. And this year it's a whole day on gun violence prevention, and there's outside speakers and internal speakers, and it's free and it's hybrid. So you can come in person or do it online. So it's a really great opportunity to really hear what's going on in the city and across the country as in regards to gun violence and gun violence prevention efforts.
Thank you very much. Dr. Meredith Belinsky, anything from Roper?
No, we actually have a few things coming up that I don't have with me, but it's everything that we've been talking about, everything with COVID is, we've noticed a decline. So that's been, I think it's been, like Katie said, it's just been awesome to see. Hopefully this starts to continue on this path. It'd be amazing. But everything that we have available at all the urgent care, express cares that we have, and then we're still we do have some things coming up with our new diversity and inclusion group, and I'll send those out to everybody, to Paul, and we can put those out as well.
Great, thank you very much. All right, and Maggie Dangerfield, have a few days of school before big spring break. Anything to report from Charleston County Schools?
Yes, sir. We're excited for the upcoming spring break for everyone. We don't have anything at this time. We are sliding into end of the year. So we've got spring break next week, and then we'll be transitioning into prep and planning for graduations. This year they're at the Coliseum and the Performing Arts Center like they were pre-COVID. So that's an exciting return there. And then, before we'll know it, we'll be gearing up for the next school year that's set to start August 17th.
Great. Thank you, Maggie. Appreciate that. And Joey Current, you have anything you want to report out?
No, just going to continue supporting all of the great health partners we've got in our community here at Trident United Way. Just a reminder for folks, it is National Public Health Week. And so if you know someone who works in public health, thank them for what they do, which I'm guessing is a lot of the folks on this call. So thank you so much for everything you do, and have a great day.
Thank you, Joey. Jennifer Roberts, anything else that you want to report out?
Yeah, I'll add a couple things. So I wanted y'all to know, so we have, we run the mobile crisis statewide call center here, and about 1/3 of the calls, we get about 700 crisis calls a month, but we take about 2,000 total. And 1/3 of those calls are people with suicidal ideation. So if we are the ones that are going to expand 988, we're probably going to have to double our team. And we're looking for space to do that, but that's exciting, because one of the good things about if we do take the 988 line, they're passing calls straight to our mobile crisis call center. And so, and we're also working with 911 dispatch because we have mobile crisis embedded there. So it's a really great opportunity for us here in Charleston and in our area to really consolidate all of that together. And so that people don't have to call 3 different people to get the help they need. So that's exciting. We are getting ready to also roll out a crisis intervention team, which is a mental health counselor and someone from Charleston City Police Department. So Mount Pleasant got a lot of law enforcement agencies applied for this grant, and Mount Pleasant got theirs. They're not quite ready to roll. Charleston City Police Department, and we are getting ready to start hiring for that team. And they will go out, and basically it's not the same as mobile crisis, but they can be a mobile crisis clinician. But they're going to go out and find our familiar faces and help them get to appointments and help them get to get their shots or medication or housing needs. So they'll have a lot more flexibility. They're not just an emergency team. And then North Charleston Police Department is kind of waiting on some hopeful additional funding to do theirs. And we're also rolling 2 teams out in Somerville area. But I also wanted to mention, as far as suicide prevention. So here at our center, we ask the question about suicide at every visit for every patient. Because we do want people to know it's something that you can talk about and we will ask you about. And we do safety planning with everybody and making sure it's up to date with people. And I just have one last thing to share. And I'm going to say I'm not really speaking on behalf of the Department of Mental Health, but it is about the Department of Mental Health. I'm sure Katie is quite familiar with this, what I'm going to talk about, but it is about the S2 bill. It passed in the Senate, and it's a restructuring bill that involves DHEC, the Department of Mental Health, and DAODIS. It is now in the House right now, and we have been just sharing factual information to our House representatives. It kind of flew through the Senate, and they didn't give a lot of opportunity for community input. But I'm speaking from my own personal opinion. But part of the thing, I guess DHEC, they've been trying to get DHEC it's a large agency, as Katie knows, and so they wanted to separate DHEC out so that it wouldn't be so large and it'd be easier to manage. But this new bill, if it passes through the subcommittees in the House and then the House floor, and if the governor signs it, it actually takes DHEC into 2 different agencies. One would be the Department of Public and Behavioral Health, and the other side would be environmental. But of the 3,000 people in DHEC now, 2,000 of them would go into the public and behavioral health side. And if you roll in DMH and you roll in DAODIS, that's 5,500 people that will be in that agency. So it's not actually making the agency smaller at all. It's making it a lot larger. And my concern, I'll say, the other part is if it does pass, it needs to happen within a year. And I can tell you, we tried to combine 2 mental health centers in Greenville, and we're in year 3 and it's still not done, right? That's a huge thing to take on. And in my opinion, it would really affect patient care for us, because DMH would have to take their eyes off the ball of patients and work on a reorganization really fast and within 12 months. So for me, I worry about patient care if it does happen. We love DHEC, Katie. You guys actually license our hospitals and our crisis stabilization center. So that's another, how could that happen if we were all in the same agency? But I just wanted to share that. And if anyone has their own concerns or wants to ask more questions of me afterwards, please reach out. But if you do have any information you'd like to talk to your representatives, if you know them, I know it's in the House right now. And I personally am hoping it doesn't pass. This is not the time. We are in a mental health crisis nationwide. And to take the focus off of patient care would be, I think, kind of detrimental to our patients across the state. What the mental health needs is more funding for we can raise salaries so that we can get our staffing back up to where it was before COVID. So that's all I have to report.
Thank you, Jennifer. I'll try to pass that along to people that I know too. So to help you out a little bit if I can. So anyone else? Did I miss anyone that needed to say anything? I did want to mention that we would like to see if our health and all policies group can get back together before the next meeting and maybe come up with a report for our May meeting if we could. I know Susan Johnson's not on here right now, but I don't know, maybe Dr. Richardson and Jennifer, if Joey, if y'all can pull that group together, I think it's important that we bring that back to this committee again, if you would. So if y'all can do that, I'd appreciate it. Anything else for the good of this committee? If not, I will say that we stand adjourned. So thank you very much for your time. I appreciate everybody, and thank you very much.
Thank you.
Thanks, Kevin.